Welcome! In this explainer, we're diving into the brand new 2026 guidelines for a really serious condition, the pulmonary embolism. You're going to see how these new rules are totally changing the game for both doctors and, most importantly, for patients.
So here's our plan. We're going to follow a patient's journey, right from those first confusing symptoms all the way to the road to recovery. We'll look at what a PE actually is, the incredible detective work that goes into diagnosing it, and how this truly revolutionary new risk system is reshaping treatment and saving lives.
All right, let's start at the very beginning. We're talking about the exact moment a dangerous little clot decides to form and starts to make its move.
You know, it all starts with a question just like this one, because a pulmonary embolism, or a PE for short, well, it often kicks off silently, far away from the lungs. Sometimes it's just a pain in the leg, something that feels like a cramp you'd be tempted to just brush off. So here's the deal. A blood clot forms, usually in a deep vein in your leg. We call that a DVT. The real trouble starts when a piece of that clot breaks free. It then travels through your bloodstream, goes right up to the heart, and then gets pumped straight into the lungs, where, bam, it gets stuck. That blockage is the pulmonary embolism, and it is incredibly dangerous because it's literally blocking blood from getting the oxygen your body needs to survive.
So let's imagine our patient shows up in the ER. They're short of breath, maybe have some chest pain. The doctors, they have to move incredibly fast, but they also have to be right. So let's walk through the diagnostic pathway they're now trained to follow.
And this right here, this is basically their roadmap. It's this super logical process that's all designed to answer one critical question: who really needs to get a CT scan? And it all begins with figuring out the probability, the chances, that this is actually a PE based on what the patient is telling them.
Okay, and that brings us to the first major fork in the road. For a lot of patients, it turns out the risk is low enough that a simple blood test, it's called a D-dimer, along with a clinical checklist, can safely say, nope, it's not a PE, no imaging needed. But for everyone else, the higher risk folks, it's time to get a crystal clear picture with that CT scan.
Now, one of the key tools doctors have in their back pocket for this is something called the years algorithm. It sounds complicated, but it's not. It's just a super powerful 3-question checklist. Are there signs of a clot in the leg? Check. Is the patient coughing up blood? Check. And finally, is a PE the most likely explanation for everything going on? The answers to those 3 questions really guide what happens next.
And the thinking behind this whole thing is so important. This isn't just about being quick or saving money. It's all about patient safety. The real goal here is to find the PEs that are there for sure, but also to protect a whole lot of patients from the radiation and stress of a CT scan they just don't need.
Okay, so let's say the scan confirms it. It's a PE. Now we get to what is truly the single biggest change in these new guidelines. It's a completely new way to answer that one question that's on everyone's mind. Just, how bad is this? To really get why this new system is such a big deal, you gotta look at the old one. See, Ps used to get sorted into these 3 really broad buckets. It was mostly based on blood pressure, normotensive just means normal blood pressure, and if the heart was showing signs of strain. The problem was, that middle submassive category was huge. It was so wide, it made it really tough to figure out the right treatment for each person.
And this is the brilliant solution. Those 3 vague buckets, gone. And in their place, we have this much more detailed 5-level system, running from Category A all the way to Category E. And what this does is give doctors just incredible clarity on exactly where a patient stands.
Let's walk through it real quick. Category A is a PE that was found totally by accident, maybe on a scan for something else. B is for patients who have symptoms, but they're still considered low risk. Then in C, we're starting to see the heart struggle a bit. Category D is the real danger zone. That patient is right on the edge of going into shock. And Category E, that is a full-blown crisis. The patient is already in shock or even cardiac arrest.
Honestly, the best way to think about this is like a weather warning system, but for blood clots. Category A, that's like a special advisory, something to keep an eye on. B and C are like a tropical storm watch, maybe a warning. But D and E, oh yeah, that's a Category 5 hurricane about to make landfall. It lets doctors match the intensity of their response perfectly to the severity of the threat.
So, and this is the most important part, this new system isn't just for putting people in boxes. No way. It's a direct roadmap for treatment. Each one of those categories has its own action plan. This chart shows you exactly how it works. You can see the categories, A through E right up top, and then flowing down from each one are the specific recommended treatments. It just creates this super clear, evidence-based path for every single patient who comes through the door.
So what does this actually mean for our patient? Well, if they're in category A or B, the guidelines say they can often be treated right at home. I mean, think about that. That is a massive shift. They can be safely sent home from the ER with the right medicine and a good follow-up plan, completely avoiding a hospital stay.
But if our patient lands in category C or D, then yeah, they need to be admitted to the hospital. These are the people who need to be watched like a hawk. They might look stable 1 minute, but things could go south really fast, so they need to be where help is just steps away. And for any patient unlucky enough to be in category E, well, that's a code red. It triggers an immediate, all-hands-on-deck emergency response. This is when the big guns come out. We're talking powerful clot-busting drugs, special procedures to pull the clot out, or even emergency open-heart surgery.
Okay, so for our patient, the journey doesn't just stop when they walk out of the hospital. Not even close. The road to recovery is really just beginning, and these new guidelines put a huge emphasis on what happens next.
This quote from the guidelines really says it all. Recovery isn't just about popping a blood thinner every day. It's about active, long-term care. Doctors are now being told, you need to check in with these patients at every single visit for at least a year. Ask them about shortness of breath, ask them if they're getting tired easily, make sure they get all the way back to their normal life.
When you step back and look at it, these new guidelines are just a massive leap forward. We're moving away from a one-size-fits-all approach to something that is truly personalized care. By getting so specific with risk, they make sure every patient gets the exact level of care they need, not too much, not too little. And it leaves you wondering, right? With the who and the when of treatment now so much clearer, what's going to be the next big breakthrough in actually getting rid of these clots for good?